In our first video, we discussed the epidemiology and risk factors for community-acquired pneumonia, and this sketch note summarizes the facts that are important for you to know. This is primarily a disease of the elderly, where the incidence is nearly 1 per 100 each year for those 65 years and older. This disease is more common in the winter, and factors that predispose to community-acquired pneumonia include viral upper respiratory infection, chronic disease, stroke, alcohol, Valium and other sedating drugs, smoking, and influenza. Now let's turn to the clinical manifestations of community-acquired pneumonia. Before reviewing the symptoms and signs of pneumonia, I want to begin with a case. A 66-year-old retired insurance salesman, heavy-set, barrel-chested man, comes to your office with a chief complaint of he's too short of breath to talk. 5 days before you saw him, he had a fever, generalized myalgias, headache, and a mildly severe non-productive cough. 3 days before you saw him, he complained of his fever increasing and the cough became more severe. Today, the cough is persistent with minimal sputum production, no chest pain. Although the patient is quite short of breath, he lights up a cigarette. His wife says he has smoked a pack of cigarettes a day for his entire adult life. Epidemiology: it is November. There's no influenza in his town. He was an avid hunter, but he has stayed at home. He has no pets and has not received an influenza or a pneumococcal vaccine. On physical exam, his blood pressure is 110/70. His pulse is 110. His respiratory rate is 30. And labored, and his temperature is 104 degrees Fahrenheit. He is cyanotic, his neck veins were distended, his lungs showed moist, crepitant rowels heard posteriorly below both scapula. His heart, there were no heart murmurs, and neurologically, there were no focal deficits, and he was alert and oriented. When assessing any infectious disease, it is important to estimate the pace of illness. Is the onset of disease acute? That is, did symptoms develop over 24 to 48 hours? Subacute, 3 to 10 days? Or chronic, symptoms progressed over 3 weeks or longer? And also to ask about specific constellations of symptoms to indicate whether the patient has typical or atypical pneumonia. Typical pneumonia usually has an acute onset and is accompanied by more severe symptoms, including a cough productive of purulent sputum and a chest x-ray showing dense consolidation. The classical atypical pneumonia presents with a subacute onset, less severe symptoms, and is sometimes called a walking pneumonia because the patient is able to continue physical activities despite their pulmonary infection. This form of pneumonia is associated with a non-productive cough or the production of a little white phlegm, and chest x-ray reveals patchy interstitial infiltrates. In taking a history, it's important to characterize the cough. How frequently does the patient cough? Is he productive of sputum or non-productive and producing only scanty sputum? Is the cough productive? Then what color is the sputum? Rusty colored, indicative of red cells leaking to the alveoli and suggestive of strep pneumoniae? A thick red currant jelly sputum often accompanies Klebsiella, while green colored sputum suggests Pseudomonas. Frank hemoptysis raises the possibility of tuberculosis or neoplasm. It is important to point out that there is considerable overlap in the sputum characteristics, and these findings cannot be considered to be specific. The next important symptom to inquire about is chest pain. Was the chest pain pleuritic? In other words, was it made worse by deep inspiration? This finding is quite specific and usually indicates inflammation of the pleura, and is often caused by pneumonia that has spread to the periphery of the lung, causing inflammation of the pleura, and may be accompanied by a pleural effusion. The lung contains no pain fibers. However, the pleura is richly innervated, and when this lining is inflamed, it is associated with severe pleuritic pain. Involvement of the pleura is most commonly associated with strep pneumoniae, group A strep or strep pyogenes, anaerobic pneumonia following severe aspiration of mouth flora, and Staph aureus. Several viral infections, Coxsackie and echovirus, can also result in pleural inflammation and pleuritic chest pain. The third important symptom to explore is shortness of breath. Was the patient short of breath on exertion, or was he or she also short of breath at rest? Shortness of breath is a worrisome symptom, and a respiratory rate of over 30 is one of the key indicators for severity and the need for hospital admission. This symptom is caused by a perfusion without ventilation VQ mismatch. When alveoli fill with edema fluid, they continue to receive capillary blood flow perfusion, but there is no exchange of oxygen, ventilation. This creates a right to left shunt. In other words, deoxygenated blood passes from the right side to the left side of the heart, resulting in hypoxia. The severity of shunting is best assessed by oxygen saturation and arterial blood gas determinations. Significant hypoxia is most common in typical pneumonia, but can be seen in some forms of atypical pneumonia, specifically influenza and Legionella. The physical exam is very helpful in determining the severity of illness, particularly vital signs and mental status. Bad prognostic signs include a respiratory rate of over 30 per minute, a systolic blood pressure of less than 90 millimeters mercury, a pulse of greater than 125 per minute, or a temperature of less than 35 degrees centigrade or over 40 degrees centigrade. A depressed mental status can accompany sepsis and or bacterial meningitis. Clinical investigations have incorporated many of the vital signs and mental status plus blood urea and nitrogen to create an illness severity score that is of prognostic value based on investigation of over 700 patients with pneumonia. It is called CURB-65 and is a simple mnemonic that you can find on MedCalc, and you simply have a yes or no for whether or not there's confusion, urea nitrogen or BUN of over 19, a respiratory rate of 30 per minute or higher, a systolic blood pressure of less than 90, or a diastolic pressure of 60 or lower, and finally an age of 65 or older. Each of these findings gives the patient 1 point, and the maximum score is 5. Patients with a 0 or 1 point have a very low mortality and can usually be sent home safely on oral antibiotics. A score of 2 is associated with an intermediate prognosis, 9% mortality, and therefore warrants hospitalization on a medical ward. And patients having a score of 3 or higher carry a worrisome prognosis of 22% risk of dying and should be assessed for medical ICU placement. For the scores of 4 or 5, ICU placement is strongly recommended. Other findings on physical exam are not reliable, and pulmonary auscultation often underestimates the extent of lung involvement. The examiner should listen for rales indicative of fluid in the alveoli, bronchial breath sounds, and egophony, E-A changes that suggest consolidation. And percussing the lung fields for dullness is indicative of consolidation or a pleural effusion. Pleural effusions are also accompanied by decreased breath sounds and in some cases a pleural friction rub. Let's return to our 66-year-old male. What is his epidemiology? What time of the year did he develop pneumonia? Does he have risk factors? How acute was his illness? Which of the 3 symptoms did he have? What positive physical findings did he have? Can you narrow down the possible causes based on these symptoms? Does he have atypical or typical pneumonia? How would you make the diagnosis? What are this patient's key symptoms and signs? He is short of breath and has a respiratory rate of 30 at rest. He has minimal sputum production and has no pleuritic chest pain. He is a smoker. Epidemiology reveals This occurred during the late fall or early winter. He was noted to have a fever, is cyanotic, has rales on pulmonary exam, and he is alert. We will discuss the likely diagnosis during a subsequent video. Now let me summarize the key points with regards to the clinical presentation of community-acquired pneumonia. When obtaining a history, it is important to explore the epidemiology and predisposing risk factors, determine the pace of illness, acute, subacute, attempt to classify the symptom constellation as typical or atypical, and when exploring symptoms, focus on three important historical findings: cough, frequency, production, and color or non-production, chest pain, present, pleuritic, 3, shortness of breath, with exercise, at rest, and apply CURB 65 criteria to assess the severity of illness. Pulmonary exam often underestimates the extent of involvement. In our next video, we will discuss how to diagnose pneumonia and how to narrow the possible causes.